everyone. I'm happy to be here and to share with you. This is a fairly recently completed project with Ed Furman, also at York, but from the Math and Stats department. And I should acknowledge the financial support of the Fields Institute through the Mathematics for Public Health program. Okay, I just see. So just a bit on the motivation. It's just a couple of observations. The first one is that when we look at most of the WHO recommended vaccines, we see that coverage has been increasing over time, although there was a bit of a dip during the COVID years. But vaccination rates do remain insufficient. And so this observation prompts the question, two questions. The first one is, what are the key drivers of the decision to vaccinate? And the second question is, what is the impact of different types of interventions on the decision to vaccinate and therefore on the equilibrium vaccination rate? The second observation is that coverage in high-income countries that provide free vaccinations, for example, against for COVID-19, is not ideal. And this suggests that there are considerations other than socioeconomic factors that drive the decision to vaccinate. And the empirical literature has certainly considered some of those factors, such as perceptions, the role of perceptions, misconceptions, trust, social influence, and subjective norms. Now, for the present study, theoretically, to the best of our knowledge, we don't have an understanding of non-economic factors driving or at least contributing to the decision to vaccinate. And we want to look at this decision in an income-constrained utility maximizing model, so just standard economic model, but accounting for moral considerations, social considerations, and this cognitive dissonance, which is a disconnect, a discomfort that arises whenever there's a disconnect between actions and beliefs. And then once we describe the decision making of the individual, we can then move to the equilibrium in a given society in which these individuals belong. And we derive Nash equilibrium because whenever the action of individuals are connected, then we get into strategic considerations, so game theoretical approach, and we adopt this concept of Nash equilibrium, which assumes that each individual does the best for themselves on the assumption that everyone else does also the best for themselves. So we look at the societal equilibrium in terms of the overall vaccination rate. We describe the conditions under which full vaccination occurs in two scenarios. In the first one, we assume that people hold different views about vaccination, but have the same values, moral and social values. In the other scenario, we assume that people differ in their values, intrinsic values, but are all exactly the same views about vaccination. And then we look at how different interventions, and in particular lockdowns, vaccination restrictions, and financial incentives affect the equilibrium vaccination rate. So let me describe the results, just in case I may not be able to get to the end of it. At least you have a summary of the results. The first one is that lockdowns are not as effective at increasing vaccination rates than vaccination restrictions, as well as financial incentives, and may actually end up backfiring. A key feature of lockdowns is that they penalize vaccinated and unvaccinated equally. They also they're supposed to reduce socializing opportunities, and by so doing, they reduce the effect of social approval on vaccination, which is a positive effect. And they end up disincentivizing vaccination. On the other hand, vaccination requirements impose a larger cost only on those who choose not to vaccinate. they raise the benefit of living in a society in which everyone vaccinates over and above the benefit of living in a society in which no one vaccinates. And because this net benefit enters positively the social approval function, they enhance the positive effect that social approval has on vaccination. We say they crowd in intrinsic motivation for vaccinating, and therefore they incentivize vaccination. And these results hold regardless of the type of heterogeneity, whether it is cognitive dissonance heterogeneity or value heterogeneity. When we compare financial incentives and vaccination restrictions, we find that qualitatively they are similar, but financial incentives are less efficient and are more socially costly. And this is particularly when social approval doesn't affect the full vaccination equilibrium. And that arises when there is cognitive dissonance heterogeneity. So what is the key difference between those two tools, financial incentives and vaccination restrictions? Well, financial incentives reward desirable behavior, while vaccination restrictions penalize undesirable behavior. And this difference, at least in the context of this model, amounts to a different effect on the net benefit of living in a society in which everyone vaccinates, which we'll call lambda, as you will see shortly. Under vaccination restrictions, this net benefit increases, and the financial incentives does not change. And so that means that vaccination restrictions have a stronger crowding in effect. So they enhance the value or the positive effect that social approval has on vaccination by a greater extent than financial incentives. Under value heterogeneity, we find that just the presence of cognitive dissonance, even if it's small, prevents full vaccination from occurring. So there is intrinsic motivation or social approval in particular as less of a role to play in that context. And because of that, then vaccination restrictions and financial incentives are not only qualitatively analogous, they're also quantitatively analogous. Okay, so what do we know from the literature? Some conceptual descriptions of what drives the decision to vaccinate actually come from the field of psychology. And there are three explanations here: health belief model, theory of planned behavior, and social cognitive theory. And they all differ in just a specific combination of factors that they argue to be driving a vaccination decision. For example, the first one, the health belief model, focuses on a combination of perceived susceptibility, perceived severity, perceived benefits, perceived barriers, cues to action, and individual and social cultural factors that influence those perceptions. So it's a perception-based argument. But these are just some conceptual descriptions. There is not a formal model. In economics, where we rely quite a bit on mathematical formulations, the questions have been, the focus of the literature has been on whether there is, how the private and social values of vaccination compare. Because there are additional benefits, additional indirect benefits in the decision to vaccinate, we would expect the private value, the individual value, to be smaller than the social value. And the social value, we account for these indirect benefits on third parties. And so that's what the literature has considered. And then because of this disconnect between social and private value, which basically amounts to a suboptimal equilibrium in terms of vaccination rate, some literature in economics has looked at the best intervention to ensure they can support the social vaccination in a decentralized environment. There is some literature in economics that has considered factors driving the vaccination decision, but those tend to be don't focus on non-economic factors. For example, we have papers on risk perception, the role of risk perception, the role of disease prevalence. So mostly just it's about the virus itself, the disease itself. Imperfect vaccine efficacy and number of available vaccines. So in this paper, we just use a model to describe the decision to vaccinate. So it's really a binary choice, yes or no, but accounting for non-economic factors. We assume that we have a society with a continuum of 0-1 individuals, and they have each of whom has to decide whether to vaccinate. So that the assumption of normalizing the population to 1 is just for analytical simplicity or analytical convenience. There's no loss of generality. A typical individual has the utility function described on the slide. It's in health terms, so everything is expressed in health terms. There are different components. You see, it's additively separable, which is not uncommon in the literature, particularly in the behavioral economics literature, which focuses on non-economic factors driving decision-making. And again, though the assumption is just to make sure that we can get analytical solutions to the problem. And it's particularly relevant here, given that the choice is binary. So utility function depends on this personal health, and I'll come back to it. I'll clarify all those terms. Then there's public health. Public health is a function, okay, it's capital H, it's a concave function of the vaccination rate. The vaccination rate corresponds to this gamma bar, which is the average contribution to vaccination. Gamma is a dichotomous parameter. It's equal to 1 if the individual decides to vaccinate, and equal to 0 if the individual does not vaccinate. So gamma bar is the vaccination rate, which we are going to label as V. Then we have, I probably should go through here. Okay, we have X, which is consumption, and Z is the marginal health benefit of X. So the role of Z is just to turn consumption in dollar terms into health terms. We have this cognitive dissonance, which is captured by this parameter theta. Theta ranges between 0 and 1. The closer to 1, the less dissonance we have. Someone who has a value of 0, a theta value of 0, means it does not believe in vaccination at all. Someone who has a value of 1 has full trust in vaccination, believes in vaccination. So anyone in between, well, will just, if that person vaccinates, so that's the value of 1, but believes as a theta of 0.5, so there's a disconnect between the action of vaccinating and the view, the beliefs on vaccination. That disconnect is 0.5, and that disconnect, that gap causes some disutility, which is a quadratic function, which is just squared of the gap between the two. So clearly this cognitive dissonance arises, this cost only arises when the individual decides to vaccinate, but does not believe in vaccination, as a value of theta less than 1. Then we have moral self-image or moral consideration that's captured by M. It has 3 components, and I'll describe those shortly. And then social approval also has different components, which I'll describe shortly. The delta and the beta are parameters ranging between 0 and 1, and they capture how important delta, how important moral considerations are, and beta, how important social considerations or social approval or social disapproval are. So let me say here that, so we allow for 2 types of heterogeneity. In one case, we assume that there is cognitive dissonance heterogeneity, so heterogeneity in theta. We assume that theta is uniformly distributed between 0 and 1, but there is value homogeneity. So the delta and the betas are common across individuals. In the second instance, I thought I had, okay. In the second instance, we have value heterogeneity, where the delta and the beta are uniformly distributed between 0 and 1, but cognitive dissonance homogeneity. People hold exactly the same view about homogeneity, about vaccination. They have exactly the same data. So these are the two cases that we consider. Okay, so what is the personal health? Well, there is an initial endowment, which is age, and then there is an expected loss. Now, this expected loss, the expected loss depends, of course, on whether the person vaccinates, but vaccination is not perfect. And so this alpha there is a parameter ranging between 0 and 1 that reflects how the fact that vaccination is imperfect. So if alpha is equal to 1, vaccination is perfect, and that protects you from contracting a virus. If alpha is less than 1, then even if you are vaccinated, there's still a possibility that you contract the virus. Then, of course, depends on if there is a lockdown, and the lockdown parameter is captured by that L, is a dichotomous parameter, 0, 1. If there is a lockdown, it's equal to 1. If there's no lockdown, it's equal to 0. I should mention here that in writing all these expressions, I'm allowing for all the 3 interventions. But then when I look at interventions, I only look at one at a time, and then I compare the 3. I wanted the expression to be as complete as possible. So in this case, the lockdown would affect the expected loss and the expected endowment loss. So when L is equal to 1, how does it affect that? Well, that pi sub h, ranging between 0 and 1, captures how effective lockdowns are at reducing transmission. If they are perfectly effective, then there is no transmission. There is no possibility of contraction for someone who has vaccinated. Actually, even for someone who has not vaccinated, because there is no contact whatsoever. But if pi sub h is less than 1, then it affects the lockdown does affect the expected endowment loss. And 1 minus v is the probability of contraction when L is equal to 0, when there is no lockdown. And this expression right here at the bottom is the probability of contraction when there is a lockdown, right? And then, all right, okay. Feel free to ask questions along the way. I don't have to wait until the end, especially just clarification questions. Okay, so the self-image function, or the moral consideration function. Yes, Mortaza?
Hi, thank you. You know, here pi depend the effectiveness of the intervention depends on how the people respond to the policies. Did you check for it or model this part? Or just take it as a parameter?
Yeah, it's a parameter. It's not a function. I mean, of course, you can make it more complicated by allowing it to depend on other things. But in this context, it's a parameter. It just yeah, it reflects how effective lockdowns are going to be.
Okay, thank you.
Effective in reducing transmission. The self-image function has 3 components. The first one is how an individual, the actions on individual relative to the ideal world. In the ideal world, gamma will be equal to 1, right? Now this individual, that's gamma, so this is the action of the individual, which could be 0, 1. If the individual decides not to vaccinate, then it will just have, it would feel a negative self-image because their actions fall short of the ideal action, which is just 1. Moral self-image or moral consideration on moral benefits also depend on the public health when everybody vaccinates. So when gamma bar of V is equal to 1. And then it depends on the share of the population that vaccinates, that's V. The social approval function has also three components. Now, the key difference between moral self-image and social approval is that in the former, the individual compares their actions to the ideal state. In the latter, which is right here, the individual compares their actions relative to the average action, right? That's the so the first element affecting the social approval function is the individual actions relative to the average. Then it's important for social approval that people actually observe your behavior, right? Otherwise, if people don't observe, then there's no benefit there's no social approval or disapproval. So there's the probability of meeting a vaccinated individual right there. It depends on K. I will have to come back to it on the next slide. Now, this probability of meeting a vaccinated person depends on how effective lockdowns are at reducing socializing. That's what lockdowns do, right? They reduce socializing opportunities, and we reflect and we capture this effectiveness in this additional parameter, pi sub s, between 0 and 1. If lockdowns they completely shut down socializing opportunities, pi sub s is equal to 1. And then if they're completely ineffective, pi sub s is equal to 0. And finally, we have a social approval also depends on the net benefit at the societal level of vaccinating. So this is the lambda, and it's just utility when everybody vaccinates minus utility when no one vaccinates. So this is the net benefit of 100% vaccination. So what is that? So this is the probability of meeting a vaccinated person, depends on K. What is K? K is the probability that you meet someone from your peer group. And then 1 minus K is the probability that you meet someone from the general population. So we have a peer effect and non-peer effect. For a vaccinated individual, those two effects are both present. So this is the peer effect and non-peer effect, which also depends on the share of the population that vaccinates. And for a non-vaccinated individual, they just the non-peer effect. And finally, we have a budget constraint. And in the budget constraint, that's the one equation where we see all the three interventions. So there's a fixed income. Well, let me just put this down. This is the fixed income, I. Now, during a lockdown, when L is equal to 1, there's an expected loss of income. And that loss of income is our expected loss is just Q times I, where Q is just between 0 and 1. If there is under monetary incentive, the individual receives this P. This is a monetary incentive if the individual vaccinates. So when gamma is equal to 1. If the individual does not vaccinate, clearly there's no incentive. On the right-hand side, we have the expenditures, so we have consumption, and then we have, this is the monetary equivalent of vaccination restrictions. Now, vaccination restrictions depend on the share of activities for which these restrictions apply. And then this is the monetary equivalent of the cost of those restrictions. So, for example, not being able to go to a restaurant unless you're vaccinated, there's not, the cost is not, initial cost is not in money terms, but there is a money equivalent of that cost. And that cost will depend on this parameter 5. We don't really do anything with 5 other than noting that, those restrictions can differ in intensity. So when 5 goes up, restrictions become stricter. And these restrictions, this cost, or this, it's a cost, right? Only applies when the person decides not to vaccinate. So when gamma is equal to 0. If gamma is equal to 1, then there is not, those vaccination restrictions don't have any cost on the individual. Okay, so these are all the relevant, so that's just the budget constraint is last piece of the model. Now, we talked about the importance of lambda. Remember, lambda is the net benefit of living in a society in which everyone vaccinates, and it appears in the social approval function positively. So the lambda drives some of the results. So just to summarize here, what are the differences across the different policies? It doesn't really matter what the expressions are. What I really want to drive home is the fact that depending on the policy, the lambda could go up or down or not change. So this is the expression under no policy. If you have a lockdown, we don't really know what happens to lambda. And I'll try to give some intuition of why we are uncertain. And the vaccination restrictions, the lambda goes up. So we talked about crowding effect of intrinsic motivation, and that crowding effect is happening because of this lambda increasing. And the financial incentives, lambda does not change. And again, I'll try to provide intuition for that. But this explains why when we compare vaccination restrictions and financial incentives, at least in some of the cases, financial incentives turn out to be less effective or more socially expensive, costly. So this is a comparison, and when we have heterogeneity in theta, the same is true when we have heterogeneity in the values, right? Under lockdown, we don't know what happens to lambda, can go up or down. Under vaccination restrictions, it goes up, and the financial incentives does not change. Okay, so now we are ready for the decision making. It's a binary decision making. The individual simply decides whether to vaccinate, and we'll do so. The individual is rational, so we'll vaccinate. We'll compare the utility when vaccinating, so that's right here, and then with utility when not vaccinating, so that's what we call delta U. If that delta U is non-negative, the individual will vaccinate. If it's positive, the individual will not vaccinate. So that's as simple as that. Now, when we have heterogeneity in theta, and theta, we're going to assume that theta is uniformly distributed between 0 and 1, then we need to talk about the marginal individual. And what is the marginal individual? Well, the marginal individual is that individual in that continuum 0, 1. So we are looking for the theta such that delta U will be equal to 0. So that's going to give us the marginal individual. It's the theta belonging to the marginal individual, and that is the individual indifferent between vaccinating and non-vaccinating. And because the utility is increasing in theta, then we know that every individual with a theta greater than theta, that theta hat, will vaccinate, and every individual with a theta less than theta hat will not vaccinate. So that means that our vaccination rate is just equal to 1 minus theta hat. This is the theta of the marginal individual, that is the individual indifferent between vaccinating and non-vaccinating. And we can express the difference, the delta U in terms of this theta hat. See, just a quadratic function, and we can solve for that theta hat. There are two solutions, but only one of them is viable. Anyway, that bottom two expressions don't really matter. Just for completeness, I wanted to have them on the slide. Now we do exactly the same when we have biheterogeneity. But here, because we have two parameters, delta and beta, we have to make there's an additional step. So we cannot really have heterogeneity along two dimensions because it makes the derivation of analytical solutions very cumbersome. So we just need to bring them together and just so that we only have heterogeneity in one parameter. When I looked at 3 data sets, and I'm familiar with these 3 data sets because I was involved in the projects. They're all environment-related projects. And they all have data on moral and social motivations. So we're just moral and social motivations, for example, for recycling. But then I look at how the moral and social motivation data behave against one another, and find that there is a positive monotonic relationship between, or correlation between the two. So in other words, there is some evidence based on, can be also anecdotal evidence, and some evidence based on 3 different data sets, that individuals who are more socially motivated are also more morally motivated, and vice versa. So that allows me to express one of the parameters, let's say delta, as a positive function of beta, and that z as a positive constant could be greater than 1, less than 1, or just equal to 1. It doesn't really matter. It's just that it allows, we know that there is this positive monotonic relationship between the two, and that allows me to to express one in terms of the other. So now, so we can then say value heterogeneity means that for value heterogeneity, we have that beta is uniformly distributed between 0 and 1, which also implies that z times beta, or delta, is uniformly distributed between 0 and 1. And then now we need to find the marginal individual, that is individual indifferent between vaccinating and non-vaccinating. We call that, you're going to call that individual beta hat. How do we find that individual? Well, we know that U is increasing in beta. So once is increasing in beta, and that means that every individual that has a beta greater than beta hat will vaccinate, so that the vaccination rate is 1 minus beta hat. And those who have a beta less than beta hat will not vaccinate. And beta hat solves delta U equal to 0. When it's a quadratic expression, 2 solutions, but only one of them is going to be viable. There are 2 propositions, and I have one for when we have heterogeneity in theta, and the next one when we have heterogeneity in value. Simply here, we have 2 Nash equilibria, one in which everybody vaccinates and low value is okay, and the other one in which only a share of the population vaccinates, and the share is equal to 1 minus theta sub 1 hat, and that occurs at high values of k. And this is a critical k. I'll come back to this critical k. When we have heterogeneity in beta, 3 Nash equilibria are possible, one in which everyone vaccinates. Now, notice here that the full vaccination equilibrium, and I should probably note here that I could have easily assumed that herd immunity does not require full vaccination, right? So some v less than 1. That would have simply added some additional parameters to the analysis without really affecting qualitatively the results, right? So in this case, the implicit assumption is that herd immunity occurs at when vaccination is complete or is perfect. Now notice here that the full vaccination equilibrium requires that we have either vaccination restrictions, that's captured by W times C, or monetary rewards, okay? Monetary rewards, a P equal to WC would be a socially, an equally socially costly intervention. But as long as there is cognitive dissonance, and this is the cost of cognitive dissonance, we cannot have full vaccination unless we have vaccination restrictions such that their value exceeds the cost of dissonance, or we could have monetary incentives such that their utility value exceeds the utility cost of cognitive dissonance. But in the absence of those interventions, there is no, the full vaccination equilibrium is not feasible. Now, suppose that that condition is not satisfied, even if we have vaccination restrictions or financial incentives, this relationship holds, in which case, for high values okay, we are going to have a share of the population vaccinating, and at the low values okay, we have no one vaccinating. Okay, now, for now, we just look at just individuals, but we're going to, just to move from the individual to the equilibrium in the society, we're going to, well, we need to talk about how whether or not the individual have information needed to decide on their utility maximizing strategy. We assume that they don't have this information, may not have this information, and assume that they learn this information through a trial and error process. And we rely on the replicator dynamics concept to describe this trial and error process. This concept, the replicator dynamic concept, postulates that the share of the population that adopts a particular strategy, let's say the vaccination strategy, grows at a rate that is equal to the difference between the payoff of the strategy and the average payoff in the population. So in other words, V dot over V, so that's the growth rate in the vaccination rate, is just equal to the difference between the payoff of the vaccination strategy, and then this is the average payoff in the population. It's a weighted average utility where the weights are vaccination rate and non-vaccination rates. And the dissonance heterogeneity, so heterogeneity in theta, we can express the V dot behavior in terms of H hat, theta hat, sorry. And then if you have value heterogeneity in beta, then we can express the V dot in terms of beta hat. And then we can look at what are the steady states. Okay, what are the steady states in this society? You can see that there are really two there. There are three. So one is when theta is equal to 0. So in that case, vaccination is perfect. Theta is equal to 1, vaccination is 0. And then when the delta U is equal to 0, vaccination rate is just equal to 1 minus theta sub 1 hat. And same here. Okay, so those are the three. However, we're not just interested in just a steady state, we're interested in asymptotically stable equilibria. So that means that if you're not quite at that equilibrium, but we are very close to it, either to the right or to the left, the forces of the game are such that we are going to get to that equilibrium. That is an asymptotically stable equilibrium. There could be other equilibria that are not asymptotically stable in the sense that unless you are at that equilibrium, any deviation from it, even if you're very close to it, you're just going to move away from it. That's not stable asymptotically. Okay, so now when we have heterogeneity in theta, we have two asymptotically stable equilibria. One in which everybody vaccinates at low values okay, and the other one in which only a share of the population vaccinates at high values okay. When we have heterogeneity in beta, we have three asymptotically stable equilibria. One in which everybody vaccinates, right? Not the second one. But again, notice that for this one, you do need vaccination restrictions, and they have to be such that they are at least as large, their utility value is as large as the utility cost of cognitive dissonance. If that condition is not satisfied, then the asymptotically stable equilibrium would entail a share of the population vaccinating at high values okay, or no one vaccinating at these intermediate values okay. So let me just now try to give you a bit more on the intuition of the results. So we talked about the critical, again, back to dissonance heterogeneity. So heterogeneity in theta. There's a critical K, and I have reproduced the critical K here. Now that second term on the right-hand side is negative, right? So K bar is less than 1. It has to be, it's a probability of meeting someone from your peer group. And we know that the steady state, an asymptotically stable steady state entails full vaccination when K is less than or equal to that critical K. Why at low values? What's happening at low values? So let's think of what happens when K goes down. When K goes down, there are two effects. One is the non-peer effect. There is an increase in the non-peer effect, which is 1 minus K times V. So that non-peer effect goes up, which increases the benefit of social approval for vaccinating, but at the same time increases the cost of social disapproval for non-vaccinating. And those two increases are of equal size, although just in opposite direction. However, there's also a peer effect. When K goes down, the peer effect, which is K itself, goes down, and that reduces the benefit of social approval. Now, when we look at the two combined, we see that because the peer effect dominates, the benefit of social approval goes down. However, it turns out that it goes down less rapidly than the increase in the cost of social disapproval. And so overall, the vaccination, there is a decrease in K corresponds to increased incentives for vaccination. Now, and that's why we have full vaccination at low values of K. Now you see that critical K depends on policies, right? So this is now I'm just looking at the different policies. So it depends on policies. So if we have vaccination restrictions, right, they are captured right there, then K hat increases, but K hat, the critical K, also increases because the lambda, the net benefit, remember the net benefit of 100% vaccination also increases. And because this term is negative, right, K hat increases again. So there are two channels through which K hat increases when we have vaccination restrictions. What does an increase in K hat mean? It means that now you're going to have more K values for which full vaccination is possible, because full vaccination requires that K is less than K bar, K hat. K hat increases, the range of K values for which full vaccination is an asymptotically stable equilibrium is now larger. So full vaccination becomes more likely. What happens if we have financial incentives? And suppose that we have financial incentives that are as costly, as socially costly as vaccination restrictions. So suppose that P is equal to just W times C. K hat also increases, but remember that under financial incentives, lambda doesn't change. So there's only one channel through which K hat increases. Overall, full vaccination becomes more likely even under financial incentives, but the crowding in of social approval is not as pronounced as under vaccination requirements. What happens if we just have lockdowns? So L is equal to 1. Well, we don't know what happens to that K hat, right? Surely this term will increase K hat, but then the lambda, we don't know what happens to lambda, could go up or down. So there's ambiguity on the effect of lockdowns on K hat, and therefore we don't know if lockdowns are going to make full vaccination more likely or less likely. Okay, and I think, so what is the problem with lockdowns? Well, they affect lambda through 3 channels: income, health, and social approval. But let me just move to this one because this is more intuitively appealing. There are 2 complications that lockdowns present. They reduce socializing opportunities, and by so doing, they reduce the benefit of social approval in terms of increasing vaccination. So they reduce the positive effect that social approval has on vaccination. So less of an incentive to vaccinate. The second adverse effect or adverse effect is that they reduce the prospect of transmission. And by so doing, they reduce the health benefit of vaccination, right? You want to vaccinate just to to stay healthy, but because now they reduce the prospect of transmission lockdowns, then the benefit of vaccination to keep your health up is lower. And the combined effect of those two complications may be sufficient to offset the income benefit of vaccination. The income benefit is captured by the fact that there is an expected income loss under lockdowns. And so the benefit of vaccination is the avoidance of lockdowns and therefore the avoidance of that income loss. Paradoxically, lockdowns can actually be effective only when those two pies are small. So that means where the lockdowns are not effective at reducing transmission, they're also not effective at reducing socializing or reducing socializing. And when Q is sufficiently high. So when that the expected income loss is high. Okay, so this is a diagram that basically describes the V dot behavior. The middle curve is the one in the absence of policy. In this case, the only asymptotically stable equilibrium is this one. The vaccination rate, what that could be 0.35, it's about 0.35. So that means that the vaccination rate is 1 minus 0.35, so 0.65, right? And that's the only asymptotically stable equilibrium. If you are just, let's say that if we are just to the right of it, then the delta U is positive. Delta U being positive means that some individuals now are going to vaccinate because the benefit for the individual vaccinating exceeds the benefit of not vaccinating. Delta U is positive. As some people start vaccinating, the social approval value increases, the self-image value increase. So other people are going to see this and they're going to also vaccinate. And this process will continue until delta hat is 0.35, right? If you are to the left, delta U is negative. Some people will, now, vaccination is not reversible, right? So it's not that, well, I vaccinate and I'm going to unvaccinate, but it is something that is required with a certain frequency. So even if someone cannot unvaccinate, you can think here of someone who decides not to renew vaccination, right? So some people will decide not to renew vaccination. That's going to affect, through V, the vaccination rate, will reduce the value of social approval, will reduce the value of self-image. As other individuals see this, they will also stop renewing vaccination. And that will just will continue until the vaccination rate decreases to these asymptotically steady state of 0.65. Now, what happens when you have vaccination restrictions or even financial incentives? The curve shifts up, right? The curve shifts up, which means that now the steady state moves to the left. So that means that your V, which is just 1 minus that, this intersection gives you the theta hat, vaccination rate is higher. With lockdowns, that's the curve shifts down, and that entails a lower vaccination rate. Now, this is the same figure, but in this case, the vaccination restrictions are such that the curve shifts by more. And you can see now that the curve just goes through 0. So in this case, the only asymptotically steady state is theta hat is equal to 0. So we have full vaccination. And remember, for full vaccination, your K has to be, this is your K, has to be less than the critical K. I don't have the critical K computed here, but it's going to be greater than 0.2. Okay, so what happens when there is value? I'm almost done, but as I say, if you have questions, just don't hesitate to ask now. If we have heterogeneity in the beta, so we have three equilibria, right? These are asymptotically stable. The first one is full vaccination, which requires the value of vaccination restrictions or financial incentives to be at least as large as the value of cognitive dissonance. We can have a share of the population vaccinating if those two conditions are satisfied, and zero vaccination right there. Okay, so just briefly, what do we observe? We observe that if there is cognitive dissonance, even a small amount of cognitive dissonance, even if theta hat is just 0.8, right, close to 1, in the absence of vaccination restrictions or financial incentives, full vaccination is not feasible. Of course, the greater the effect, the more cognitive dissonance we have, so the smaller the theta hat, the smaller the theta, the more costly vaccination restrictions have to be for full vaccination to arise. And vaccination restriction, the cost of vaccination restrictions depend on that W. So it could be achieved, an increasing cost could be achieved by having more activities prevented if unless someone is vaccinated, or by increasing the intensity of the restrictions. Okay, so here I have, I mean, it's very much the same story. So the middle one is non-policy. This is the only asymptotically stable equilibrium. Vaccination restrictions shift the curve up, increasing the share of the population that vaccinates. Lockdown could reduce, most likely reduce the curve, shifts the curve down, therefore reducing the share of the population that vaccinates. Now, this is an instance in which lockdowns are actually effective, right? Lockdown shifts the curve up, increasing the share of the population that vaccinates. But I want to draw your attention to the parameter values that I had to assume to get this result. The two pi's are very small, 0.1, 0.1, in a range of 0, 1, which means that lockdowns are highly ineffective at reducing transmission, highly ineffective at reducing socializing. And the cost, income loss, has to be very large, 0.8. For each dollar of income, you're losing 0.8. But it is possible for lockdowns to increase the share of the population that vaccinates in the steady state. And this is the last slide, which compares vaccination restriction and monetary rewards. I've already described some of the results. It's just expressions that show those results. So I can pause right now. I mean, I'll cover it, but given that we only have 5 minutes, I can pause and see if there are questions about the work.